Welcome to Inside Biology. My name is Wilson, a biology enthusiast. Today's episode revolves around the major risk factors of liver disease. The liver is one of the body's most vital organs, performing essential functions in metabolism, detoxification, immunity, and nutrient storage. However, several risk factors can compromise its health, leading to chronic liver disease, cirrhosis, and even hepatocellular carcinoma, or HCC. In this video, we explore the 5 major risk factors that damage the liver, breaking down their mechanisms, disease progression, and clinical significance. Now let's talk about alcohol abuse and its impact on the liver. The liver is the primary site for alcohol metabolism. When alcohol or ethanol enters the body, it's broken down mainly by 2 enzymes, alcohol dehydrogenase, also known as ADH, and cytochrome P450E1, or CYKE1. This process converts ethanol into acetaldehyde, which is a highly toxic compound, and then into acetate, which is less harmful. However, chronic and excessive alcohol intake overwhelms this metabolic system and leads to multiple harmful effects. First, there's fatty liver, also called alcoholic steatosis. The mechanism here is that excess alcohol increases the liver's production of NADH, a reducing agent, and this disrupts normal fat metabolism. This promotes triglyceride accumulation inside hepatocytes or liver cells. The outcome? The liver becomes enlarged and filled with fat droplets. This is actually the earliest stage of alcoholic liver disease. And the good news is it's often reversible if alcohol consumption stops. Next, let's look at alcoholic hepatitis. The mechanism here is that prolonged alcohol exposure generates acetaldehyde and reactive oxygen species, or ROS, which cause oxidative stress and direct hepatocyte injury. When liver cells are damaged, they release danger signals that activate Kupffer cells, which are liver macrophages. These immune cells then secrete pro-inflammatory cytokines like TNF-alpha and IL-6 that amplify tissue damage. On histology, you'll see ballooned hepatocytes, Mallory bodies, which are damaged cytoskeletal proteins, and infiltration of neutrophils. The outcome includes jaundice, abdominal pain, fever, and honestly, significant liver dysfunction. So let's talk about cirrhosis. With repeated cycles of injury and inflammation, the liver tries to repair itself by producing fibrous scar tissue. Over time, normal liver architecture is replaced by fibrosis and these regenerative nodules, which really disrupt blood flow through the organ. The outcome is that the liver becomes stiff, shrunken, and it loses a lot of its functional capacity. Complications can include things like portal hypertension, ascites, variceal bleeding, hepatic encephalopathy, and even liver cancer, also known as hepatocellular carcinoma. Now, moving on to hepatitis B and C, also known as HBV and HCV, and their impact on the liver. Both hepatitis B virus and hepatitis C virus are what we call hepatotropic viruses, meaning they specifically target those liver cells or hepatocytes. Even though they differ in structure and how they replicate, both of them can cause chronic inflammation, persistent cellular injury, and progressive liver damage. This, in turn, ultimately increases the risk of cirrhosis and hepatocellular carcinoma, or HCC. Next up, hepatitis B virus, or HBV. So HBV is a DNA virus that belongs to the Hepanaviridae family. It has this unique life cycle where its DNA is converted into something called covalently closed circular DNA, or cccDNA, inside the nucleus of hepatocytes. This cccDNA can actually persist allowing the virus to remain dormant or, reactivate later on. Now, when it comes to pathogenesis, HBV itself isn't directly cytopathic. It doesn't directly kill liver cells. Instead, liver injury mainly results from the host immune response. Cytotoxic T lymphocytes, or CTLs, recognize infected hepatocytes and destroy them. Chronic immune-mediated attack leads to persistent inflammation and hepatocyte turnover. And with repeated cell injury and regeneration, there's an increased chance of DNA mutations, which can promote carcinogenesis. So let's talk about the clinical course of hepatitis B virus. In cases of acute HBV, many infections actually resolve on their own, with folks making a complete recovery. But when the immune system can't quite clear the virus, chronic HBV develops. This can lead to chronic hepatitis, fibrosis, cirrhosis, and in some cases, even hepatocellular carcinoma. The virus has the ability to integrate into the host genome, which directly contributes to the development of cancer. Moving on to hepatitis C virus, or HCV. This is an RNA virus from the Flaviviridae family. Unlike HBV, HCV doesn't integrate into the host genome, but its high mutation rate helps it dodge the immune system and set up a chronic infection. When it comes to pathogenesis, HCV causes direct cytopathic effects, meaning it actually damages liver cells directly. It also triggers oxidative stress and mitochondrial dysfunction, which messes with normal cell metabolism. Chronic infection keeps the immune system activated, leading to ongoing inflammation and fibrosis. Over time, this cycle of liver cell injury and regeneration increases the risk of DNA mutations and eventually malignant transformation. As for the clinical course, about 75 to 85% of acute HCV infections end up progressing to chronic hepatitis. Over the course of decades, this can develop into cirrhosis, liver failure, and even hepatocellular carcinoma. Unlike hepatitis B, there's no vaccine for HCV, but the good news is that direct-acting antivirals can now cure more than 95% of infections. Non-alcoholic fatty liver disease, or NAFLD, is actually a spectrum of chronic liver disorders, and it's characterized by the accumulation of fat, what we call hepatic steatosis, in at least 5% of hepatocytes in individuals who consume little or no alcohol. It's become the most common cause of chronic liver disease worldwide, and it's closely linked to obesity, insulin resistance, type 2 diabetes, and metabolic syndrome. So, let's talk about the pathophysiology of NAFLD. This disease develops due to a combination of metabolic, hormonal, and inflammatory factors. The most widely accepted model is the multiple hit hypothesis, which includes a few key players. First, there's insulin resistance, which impairs glucose metabolism and actually promotes increased fat breakdown in adipose tissue. This ends up flooding the liver with free fatty acids, leading to triglyceride accumulation inside hepatocytes. Next, lipotoxicity comes into play. Excess free fatty acids are metabolized incompletely, generating toxic lipid intermediates like ceramides and diacylglycerols. These damage hepatocyte mitochondria and induce oxidative stress. Now, with overloaded mitochondria, we get increased production of reactive oxygen species, or ROS. These reactive molecules damage cell membranes, proteins, and DNA, leading to hepatocyte death. Damaged hepatocytes then release signals that activate Kupffer cells, which are the liver's resident macrophages. These cells release pro-inflammatory cytokines, things like TNF-alpha, IL-6, and IL-1 beta that drive further injury and attract more immune cells. Finally, Chronic inflammation activates hepatic stellate cells, which start depositing collagen and extracellular matrix. This scarring impairs blood flow and liver function and can progress to fibrosis and cirrhosis. Now, when it comes to the stages of NAFLD, there are three main ones to keep in mind. First, we have simple steatosis, also known as non-alcoholic fatty liver. Here, fat accumulates in hepatocytes, but there isn't significant inflammation or fibrosis. It's often asymptomatic, and the good news is it's reversible with lifestyle changes. Second, there's non-alcoholic steatohepatitis, or NASH. This stage is defined by steatosis along with inflammation and something called hepatocyte ballooning, which is basically cell injury. NASH represents the more aggressive form of NAFLD and is strongly associated with progression to cirrhosis. Finally, the third stage is fibrosis and cirrhosis. Chronic inflammation at this point leads to scar tissue formation and remodeling of the liver structure. Cirrhosis, in turn, increases the risk of hepatic decompensation and hepatocellular carcinoma, or HCC. Autoimmune liver diseases, or AILDs, happen when the body's immune system mistakenly targets its own liver cells or biliary structures. This leads to chronic inflammation, tissue injury, and eventually progressive fibrosis. Unlike diseases that are caused by viruses or metabolic issues, these ones are, driven by immune dysregulation and a loss of tolerance to the body's own antigens. There are three main autoimmune liver conditions: autoimmune hepatitis, primary biliary cholangitis, and primary sclerosing cholangitis. Autoimmune hepatitis, or AIH, is all about the loss of self-tolerance, where the immune system just fails to recognize liver cells as self. It's usually triggered by a mix of genetic predisposition, like HLA-DR3 or HLA-DR4, along with environmental factors such as viral infections or even certain drugs. The immune attack involves T cells and autoantibodies like ANA, SMA, and anti-LKM1 going after hepatocytes and causing necroinflammation. If you look at the histology, you'll see something called interface hepatitis, which is basically inflammation at the junction of portal tracts and liver lobules. The clinical course can range a lot, from no symptoms at all to severe fulminant hepatitis. If AIH isn't treated, it can lead to fibrosis, cirrhosis, and even liver failure. The good news is it usually responds well to immunosuppressive therapy, especially corticosteroids and azathioprine. Primary biliary cholangitis, or PBC, is characterized by an autoimmune destruction of the small bile ducts within the liver, which impairs bile flow, a condition known as cholestasis. It's usually associated with the presence of anti-mitochondrial antibodies and high levels of alkaline phosphatase. Genetic susceptibility, like certain HLA variants, and environmental triggers, such as infections or chemicals, also play a role. The main mechanism of injury is T cells attacking cholangiocytes, which are the epithelial cells lining the bile ducts. This chronic injury leads to bile stasis, then hepatocellular damage from bile acid buildup, and eventually fibrosis. Clinically, people might experience symptoms like fatigue, itching, called pruritus, and jaundice. If left untreated, progressive cholestasis can lead to cirrhosis and even increase the risk of hepatocellular carcinoma. Treatment usually involves ursodeoxycholic acid or UDCA, which helps improve bile flow and slows down the disease progression. So, primary sclerosing cholangitis, or PSC, is a chronic and progressive disease, that's really marked by inflammation and fibrosis of both intrahepatic and extrahepatic bile ducts. It's strongly associated with inflammatory bowel disease, especially ulcerative colitis. The exact cause isn't totally clear, but autoimmune mechanisms are definitely suspected. On histology and imaging, you'll often see a kind of beading appearance on cholangiography, which is due to alternating duct strictures and dilations. There's also this periductal onion skin fibrosis that's pretty characteristic. Over time, PSC leads to progressive cholestasis, recurrent cholangitis, and eventually cirrhosis. Patients are at a high risk for developing cholangiocarcinoma, which is bile duct cancer. Unfortunately, there is no curative medical therapy available, and liver transplantation is often needed in advanced cases. Next up is drug-induced liver injury, or DILI, and its impact on the liver. So, DILI is basically liver damage that's caused by prescription medications, over-the-counter drugs, herbal remedies, or even some dietary supplements. It's actually one of the leading causes of acute liver failure in a lot of countries, and honestly, it accounts for a significant number of liver transplants. The liver is especially vulnerable because it's the body's main detoxification organ, metabolizing drugs through these really complex enzyme systems. But here's the catch. These same metabolic processes can actually produce toxic intermediates that end up harming hepatocytes. Now, let's talk about the mechanisms of DILI. DILI can occur through two major pathways, and the first is intrinsic or predictable DILI. This type is dose-dependent and reproducible. A classic example would be acetaminophen, also known as paracetamol, overdose. Under normal circumstances, it's metabolized by glucuronidation and sulfation. But when there's an overdose, too much of the drug gets metabolized by CYP450 enzymes, which produces a toxic metabolite called NAPQI. NAPQ depletes glutathione, leading to oxidative stress, mitochondrial dysfunction, and ultimately hepatocyte necrosis. The onset can happen within hours to days, which is pretty fast. So, let's talk about idiosyncratic or unpredictable drug-induced liver injury. This type isn't related to the dose, and, well, it only happens in people who are particularly susceptible. It's usually caused by genetic, immunological, or metabolic differences among individuals. For example, amoxicillin clavulanate can lead to cholestatic injury, while isoniazid might cause hepatocellular injury. Herbal supplements like green tea extract, kava, or even anabolic steroids can also be culprits. And just to note, the onset can range from weeks to even months after exposure. All right, let's talk about the patterns of liver injury in drug-induced liver injury, or DILI. So DILI actually shows up in a few different histological and clinical patterns. First, we've got hepatocellular injury, which is mostly damage to the hepatocytes. You'll usually see a much higher ALT compared to ALP. Classic examples here would be isoniazid and acetaminophen. Next is cholestatic injury, where the main problem is either damage to the bile ducts or impaired bile flow. In this case, ALP is much higher than ALT, and some common culprits are amoxicillin clavulanate and chlorpromazine. Then there's mixed injury, which, as the name suggests, combines features of both hepatocellular and cholestatic types. Drugs like phenytoin and sulfonamides can cause this pattern. Now, when it comes to clinical outcomes, DILI can range from mild transient injury, which honestly often resolves once the offending drug is stopped, to more severe scenarios. Acute hepatitis can show up with symptoms like jaundice, fatigue, abdominal pain, and of course, elevated liver enzymes. Acute liver failure is a rapid loss of liver function with signs like encephalopathy and coagulopathy. It's worth noting that acetaminophen overdose is actually the most common cause of acute liver failure in the West. Finally, there's chronic DILY, where the injury sticks around and, in some cases, progresses to fibrosis, cirrhosis, or even hepatocellular carcinoma, though that's pretty rare. So here's the big takeaway. Protecting your liver really means taking a multi-pronged approach. That includes lifestyle modifications like eating a balanced diet, getting regular exercise, and limiting alcohol intake. Vaccination and antiviral therapy are super important for viral hepatitis. Early diagnosis and treatment are key when it comes to autoimmune conditions. And of course, being cautious with drug use and monitoring for hepatotoxicity can make a huge difference. In conclusion, these 5 major risk factors, alcohol abuse, hepatitis B and C non-alcoholic fatty liver disease, autoimmune liver diseases, and drug-induced liver injury, really show just how many different threats there are to liver health. Even though the causes are different, whether they're toxic, viral, metabolic, immune, or drug-related, they all share some common pathways like oxidative stress, inflammation, fibrosis, and carcinogenesis. By understanding these risk factors, we can take proactive steps to preserve liver function, prevent chronic disease, and reduce the global burden of liver-related mortality. Please like, share, comment, subscribe, and press the bell for more educational content. And thank you so much for watching.